So we'll move on to avoiding the use of tourniquets. I understand that a lot of experienced arthrofibrosis surgeons avoid tourniquet use, and I know from my reading of the scientific literature that there's pretty good evidence now that tourniquets increase hypoxia, which is lack of oxygen in the tissues, inflammation, post-operative bleeding, and can have other negative side effects like nerve damage. And all of these are powerful drivers of fibrosis. So from my perspective, it makes a lot of sense to avoid tourniquet use. Dr. Rosenberger, could you please tell us about your practice with tourniquets?
So we never use tourniquets if we have to open up the knee, and we never use tourniquets. It's mounted, but we don't need it. Don't use it, and we don't need it because if it's bleeding, I want to see it where it bleeds. I want to stop it. So that's for me easy, and it's easy there is to reduce the amount of trauma to the knee. If we do it arthroscopically, then we always start with the tourniquet turned off. But sometimes we must turn it off because it's bleeding so much that you cannot see anything. So no anatomical structures, then we have to turn it on. But in all other cases, we don't need it.
I saw a paper recently about reducing a patient's blood pressure when using that no tourniquet approach to try and slow down the bleeding. Have you tried that?
Yeah. We tried this. We do this, yeah? Yeah. And anesthesiologists, they do that, yeah? It's very important for us. And we can see the difference. It's a very important point.
And Tranix, the...
Yes, of course. It's standard, yeah? It's also in routine TKA, it's standard, yeah?
Yep. Mm-hmm. And what about when you do a primary total knee arthroplasty? Do you use tourniquets then?
No. I quit using it, the tourniquet, I think in 2012. So I never use it, never. It's in primary TK and also not in revision knee surgery. It makes no sense to me. I don't need it. So maybe if you have the arteria here in the back, maybe maybe you need it for that if it gets injured, but you don't have this usually. So we never need TKA. We never need the tourniquet. I think the studies tells us, that the risk of thrombosis or embolism or infection can also be reduced by avoiding the use of the tourniquet. So
I think some surgeons. I think some surgeons would be interested to know if there's a problem with the cement setting in the TKR scenario.
Never seen any problem with the cement setting. I've never seen one problem with this, and we never use it, and we never have a problem with cement settings. So I don't know this. It's a miracle to me. So what do you think, Jason or Kristoffer, in TKA?
Well, I don't do TKA, so that would be anecdotal. So I don't know about you, Jason, but I completely agree.
Yeah, I don't do TKs either, so that would be anecdotal, but I haven't heard of anything also, right? So I completely agree that with arthrofibrosis surgery, we never use the tourniquet. So I think pretty consistent notes across the board, but it is interesting, right, of overall, and I think you talked about it in that arthroscopy, we do use the tourniquet a lot. So I don't want to say that also in our arthroscopy and minimally invasive surgery, for the reasons that you have already discussed, that we don't use it because sometimes visualization with the arthroscope is otherwise difficult without the tourniquet in routine surgeries. And I think if, I'll just say my experience is if we do something that involves bone and transplantation, et cetera, that if we have one patient that we don't use the tourniquet, the other one we do, that the use of the tourniquet makes the surgery much faster, less less invasive as far as we can get things done quickly through smaller approaches because we can see and get things done, and they end up having less swelling and less pain afterwards. All right. That said, we always really take what we have all talked about as the tenet here, post-operative pain control and the control of arthrofibrosis is putting, if you use it, put the tourniquet down. And then you're done with your procedures, you have your visualization and making sure that you have really achieved hemostasis. And for us in the joint arthroscopically, then we use those same radiofrequency ablation if we're going to use the tourniquet to make sure that when then the tourniquet is down, that we have the same control of the local bleeding as we did before. So in our art, it's not that tourniquet has gone away, because that's far from the truth, but I think it has gone away from just not controlling bleeding and just using the tourniquet, and certainly has gone away in arthrofibrosis.
Very helpful. Thank you.
I agree. For me, it's a bit opposite. I mainly do arthroscopic surgery, and I hardly ever use tourniquet. But I don't know. I worked in Melbourne for a period of time, and there they didn't use pumps to elevate the water pressure. You just you elevated the water, and by that way you got water pressure into the knee joint. And doing that, you need tourniquet because you cannot provide enough pressure. But using a modern pump, the problem is less, at least, I would say. Yeah.
Thank you. So we've already covered the next topic, which we're going to talk about minimizing the surgical procedure, but I think we've covered that pretty well already.
If I can add one thing, then I think the main key is what my Australian mentor said back then, that you need to, surgery is about correct handling of the soft tissue and short surgery time is the two main aspects. And if you can do that, then you're well off.
100%.
Excellent. Thank you. So the next question is about bleeding and ensuring that it's stopped before closing up the wound. So Dr. Barfod, can you tell us about your procedures in that regard?
Yeah, I think it starts when you make the incision, because you need to keep the bleeding away. So it is about correct handling of the soft tissue and cauterizing the small bleeders. And if you've done that, you don't have that much of a problem afterwards. If in the cases where I cannot control the bleeding, I put on a very strong compression bandage for 30 to 40 minutes when they go in the wake up area, and then we take it off. And I hope by doing that to avoid some of the post-operative bleeding. And then they have a less compression bandage on for the next 24 hours. And then they start physiotherapy.
Excellent, thank you. So then we get on to continuous passive motion, or CPM, which has been a little bit controversial in the past. From my reading, there's some evidence that CPM reduces inflammation and helps maintain range of motion, especially in that immediate post-operative period. So Dr. Dragoo, can you tell us about your experiences with CPM?
Yeah, well, first, when I was in my training, everything was using CPM. No doubt that it can have some benefit, despite the literature that maybe lacks a little proof, right, of its efficacy. But certainly can have its place over time. What has happened is that's become another expense in a medical system that has been pretty expensive, have been unable to see the difference of results versus what I think our whole group has saying is this very coordinated physical therapy starting day one after any type of surgery. And so for me, no longer using CPM because of lots of different reasons, some of which are technical, some of which are expense, and some just a lack of of perceived benefit, but the perceived benefit has been that that patient has already had their physical therapist linked up to them before surgery, seeing the physical therapist on day one after the surgery, and continuous physical therapy rather than continuous motion machines. And with that early education of the patient of what they can do from a motion perspective on their own, during the times when they're not in the physical therapist's office, but they are seeing the physical therapist, well, especially with arthrofibrosis, around 3 to 4 times during the week of the time of surgery and the weeks, weeks number 1 through 6, put it that way, just to try to do it. So that has replaced that individualized, very quick physical therapy. Integration has replaced the CPM in a majority of the practices. In the United States, CPMs are much more rare now than they used to be even 5 years ago.
So, Dr. Barfod,
it's the same in Scandinavia. We seldom use CPM machines. We use them sometimes for flexion deficits, never for extension deficits. Then we sometimes use some kind of extension braces or casts, and intensive physiotherapy. It's the key.
Dr. Rosenberger?
So I think the CPM, it was standard, I would say, till 2010, 2012 in Austria. They were in middle Europe. So it was standard. So every patient got it after TK and sometimes after ACL reconstruction. And then all the rapid recovery programs skipped it. They said not necessary, you don't need it, it's expensive, etc., etc. But the interesting thing for me was that the patient missed it. They were always asking, "Hey, I want to have this machine, right? I don't get it. What are you doing with me?" So after 6 years, I started again using it, the CPM machines, and my patients love it, and I love it. And especially in arthrofibrosis, I think it's a good thing. It's good against swelling. The patient can see that the knee moves, and it's a program for me when he has a rest and he's lying in his bed. So I love it, and I always recommend it. So I think it's good. It's a good thing in arthrofibrosis.
I agree.
Do you also use it for extension deficits, Ralf, or just for flexion deficits?
Just for flexion deficit, or just to get a good flexion. Yeah.
Makes sense. Yeah.
And against swelling, I think it's a good thing. Yeah.
And we know that it helps to move the lymph, and just the cyclic stretch of the myofibroblasts actually deactivates the stress fibers within those cells temporarily. So these effects can actually add up, as long as it's done very frequently. And I think there's a lot of historical problems with the use of it. One is the misunderstanding of how to use it, and the idea that it's a manipulation without the anesthesia, where it's really cranked and actually tears tissues and creates bleeding, which of course is really what you don't want to do. So the IAA always advocates pain-free CPM, just if there's a flexion deficit, just to get on top of that inflammation and keep that motion, because sometimes even quadriceps activation for some of these people is too much and can increase that inflammatory response to the Hoffer's fat pad, for example. That's my thoughts.
I agree with you.
And we don't know. It's that's another study we need to make.
Absolutely, and that's the other problem historically, is that these studies were done on the general post-operative population, not on arthrofibrosis patients. So you're dealing with somewhere between 5 to 10% of the population who might benefit from it, who when the other percentage of the population won't. So you're already skewing the results there and washing out that potential signal. So we definitely need a proper controlled study on CPM use, in my opinion. So my next question, Dr. Rosenberger, can you tell us about your physiotherapy approaches post-op, and do you advocate for gentle physiotherapy?
Yes, so aggressive exercise is maybe the right thing for maybe Cristiano Ronaldo or for Henrik Kristoffersen in Norway or for the American football players. But in arthrofibrosis treatments, it's a no-go. It's a no-go. You cannot recommend this. Very important in the treatment, in the physiotherapy is 100% consequence of the patient and from the physiotherapist. You have to be extremely focused in arthrofibrosis treatment, but you should not put any force on the knee. No force. The physiotherapy should be focused on micromobilization of the patellofemoral joint, on the tibial gliding in flexion, so the movement from the tibia anteriorly, posteriorly, this gliding in flexion is very important for us. Then on the gait in general and on the tissue. And my physiotherapist, you know him, Ottmar Hauer, he always tells me, so you should work with the tissue and not against it. So that's for our point of view very important. And we always try to bring the patient back to activity. So we love the ERG using possibly combined with a pedal arm, which is reducible in length, and a pedal pendulum. So the combination, reducible length and pedal pendulum. So to bring in on the ERG, because we can move reduce the scar tissue in the knee with surgery, but there's still, there's still the arthrofibrosis between in the muscle. And to reduce the stiffness in the muscle, we think that the activity is extremely important for the patient. Extremely important. How are you doing it in Norway, Kristoffer?
We are learning, I would say. I think it's very divided in Copenhagen, in Denmark. Some physiotherapists and clinics are less aggressive, and some are very aggressive. And I think we're a little behind and doing maybe too much aggressive physiotherapy. I haven't really gotten my own head around it yet. But I think you have a point that we shouldn't push it too much. The problem is when they crawl back up and get stiff again, should you then push them out into the range where they have pain, or should you keep away from the painful range? I don't know.
I have fairly strong opinions on that subject.
Yeah.
Which is pain-free. Yes.
Yeah, and it might be right. It might be right.
I've personally experienced a very minor bleed from the range of motion being pushed beyond where it should have, which had a devastating impact that was permanent for me. So pain-free is my approach.
Yeah. What do you say, Jason? Do you go totally pain-free, or do you push it a bit?
Well, we have the saying, I think we're actually, all pretty similar in saying physical therapy is good, yet it has to be the right physical therapy, right? For me, our motto is movement is good, weight bearing and force is bad. And so what we do is a very similar type of physical therapy where it's about mobilization of, again, the tibiofemoral joint, but also the patellofemoral joint. It's about compliance of soft tissues. It is about movement, meaning movement a lot versus just letting them set after surgery. So moving, yes, the rate of movement is slow. So this is not a rapid thing. This is very slow movement patterns. It is the attempt with movement of keeping range of motion that has been achieved with surgery. That's a mission, right, of trying to do that. And at times that gets to the point of, we have a day 1, we keep it day 2, we keep it day 3, we keep it day 4, and sometimes, gets a little sore, and so then pushing them and keeping the range of motion into the same motion, but into the uncomfortable zone is sometimes what we do, and again, manage it by all the ways that I talked about previously with the medications and that sort of thing, and management of the body's response to it. But in the same time, with like Dr. Rosenberger, we do not load the joint at the beginning. This is not about weightlifting and muscle development. This is about very individualized, minimal amounts of force, but significant amounts of movement. So that's how we have had the best results in our physical therapy program, and maybe the best results of maintaining the range of motion that we originally achieved in the operating room.
Excellent, thank you.
Can I pose a quick question then? Is there any clinical evidence that this is true? I know we have the feeling that this might be the case, but do you know of any studies showing that this actually is true? Or is it also anecdotal? Please help me say that word, anecdotal.
Can I talk about the perspective from organ fibrosis research, where there is a lot more data out there compared to arthrofibrosis, where we know that there's a lot of interactions between the nerves, the immune system, and fibrosis, and there's feedback effects between all of these. So if the nerves are unhappy or the immune system's unhappy, you're going to be making the myofibroblasts more activated. So you want to keep all of those systems as settled as you can, as is possible. So if you're pushing into pain, you're triggering the nerve response. And if you're creating any sort of tissue damage, bleeding, swelling, then that's triggering the immune system, and that's triggering the myofibroblasts, the things that make fibrosis. So from my perspective, I can say that in organ fibrosis, there would be evidence to avoid upsetting the nerves and the immune system.
Mm-hmm.
But Kayley, so
that is very interesting, but still we have no clinical data, or
right, because it's just how do we study that, right? How do you study we're stopping at pain, and then we're measuring range of motion over time versus pushing into some discomfort, and then the whole pain is really hard to study and to quantify, and for the patient or for the physical therapist to, I don't know, it's a hard study, right? Thinking through the mechanics of how we would study it. I totally agree, Kristoffer, we need to study it, but that would be a great thing for this group, because that's a great, I don't know, maybe even initial study is that we do our releases, we have a certain amount of achievement of range of motion that we can document, and then do even a study or even a registry of the physical therapy systems and how do we really maintain that over time. And then when we see results of thousands of patients, maybe we can at least come up with a little bit of a understanding of what worked and what didn't. But Kayley, so it's interesting, right? Because then from the doctor perspective, I understand exactly what you're talking about, but this is a very fluid, dynamic day to day. So if you're, from your physical therapy perspective, if you achieved 110 degrees, let's just say, and you have been doing that, and then on day number 7, that 110 degrees became, let's just call it uncomfortable, not into the pain and the pushing and tears and all of that. It just became uncomfortable. Do you think the data is telling us that we should then on that day not go to 110 and go to 105, and then if 105 is a little uncomfortable, we go to 100? Do you still feel that that's the right call? Because that is a slippery slope. Like if you're a physical therapist, you would say, holy cow, my gut is starting to churn because we are going backwards at the time with which we should be going forward. And so what do you think as far as that kind of fine tuning things, and that's a totally different scenario, by the way, than, hey, this patient has had essentially no range of motion, and we were able to get preoperative to 60 degrees. Then we got them to 90 with surgery, and then we're trying to push to 110. So that's different, right? Because then they were at 90, we're pushing them to 100, they became painful, and, you know, quite possibly, again, setting into the whole, we're pushing beyond what the envelope of their range of motion is. That's even a different question than maintenance of something that was achieved already, right? We would say we easily achieved a certain amount of surgery. Should we be able to hold them at that, even if there was some uncomfort with physical therapy? What's your guys' reaction to that?
Can I jump in there? Yeah, I think that's a very important question, and there's a very important distinction in my mind between discomfort and pain. So even on the CPM, I always say don't go into pain, but I think a small amount of discomfort is possibly necessary, and I liken it to the discomfort of like pushing a finger backwards, for example. So you can push it back, you feel, okay, that's uncomfortable, but I can do it. It's not really painful. So if you go to that level, and the patient, I feel, needs to be in charge of the CPM, and I don't like external pressures being put on that the patient's not in control of, because they're the expert on their knee after all. They know what they're feeling. So they say when to stop, and it stops. They're in control. So if they're feeling some discomfort, then even just having that control can encourage them to push into that discomfort a little bit without going into the pain. So hopefully avoid that tearing of tissues, and you don't get into that cycle. But I also think that you would expect on day 7 for there to be some reactivation of myofibroblasts. They will still be there. They will still have that memory of the insult. There's still going to be inflammation, so you will have some loss of range of motion, and I think my personal feeling is that patients should be counselled to expect that, not to panic. They may not get back to the way they were before, but yeah, that is my feeling on the subject. Dr. Barfod,
I think it seems really reasonable, and there's a lot of patient education to be done, and a good communication with the patient is key in order to move them. I have enjoyed the discussion very much. Unfortunately, I have to leave in a few minutes, so I don't know if we should wrap up or if you want to continue.
Sure, I think we've pretty much covered all of our topics very nicely, and I really appreciate you all joining us. It's been a fabulous discussion, and I'm sure it's going to be of great interest to surgeons internationally all over the world, and to patients as well. So thank you very much. And we'll call it a night.
Well, thank you so much for the possibility to join.
Thank you.
And for moving the field forward, Kayley.
Appreciate it.
Bye bye,
Appreciate your time.
Thank you. Thank you.
And
Bye
your
bye,
excellent
Thank you, guys.
expertise. Thank you.
Ciao.
Ciao.